and welcome to session number 5, Planning for Sustainability, Data and Quality Metrics. My name is Liz Manley, and I'm very happy to be here with you today. I am a senior advisor for health and behavioral health policy at the Institute for Innovation and Implementation, and I'm very happy to let you know that we have a terrific panel for all of you today. For those of you who are looking for Jeff was not able to join us today, but we're really excited about having members of his team here today to talk about the work that has happened in Connecticut at CHDI. And I'm going to give them a minute to introduce in a couple of minutes. But this is our panel for today. Again, I'm Liz Manley. We have Kelly Randall with us. Kelly, do you want to say hello? Just wave, say hello. So folks
hello.
Thank you. And Sarah Becker. Sarah, you want to say hello? There we go. And Hazelyn Pilgrim. For folks who have joined us before, you know that Hazelyn is one of our ongoing members of this particular panel for all of our topics. We're really excited to have Hazelyn with us. And we're going to start with Hazelyn in just a minute. Let me just go through the learning objectives for today. Our goal today is to describe the role of data collection within the implementation and sustainability framework, describe short and long-term outcomes, and participants will become familiar with strategies for data collection. The real hope for us today is that we have a conversation about the importance of data collection, where it fits within not just mobile response and stabilization, but how it can play major roles in helping to elevate youth voice, parent voice, engage our communities and understanding how systems are operating and how they work. So in other words, we're really hoping to get to some level of transparency in not only the data collection, but how we use and share the data story. So without further ado, we're going to start today's conversation with Hazelyn. Hi, Hazelyn, how are you?
Great. How are you, Liz? Good to be here with you all.
It's always good to see you. So, Hazelyn, do you want to talk a little bit about the role of data collection in from a parent's perspective, and then maybe you and I can talk a little bit about the building of the Interagency Coordinating Council's data dashboard.
Certainly. I first thank you, Liz, for that opportunity. I think that one of the most important things we have learned over our years of this evolving system is the value of sharing data with youth and families. Oftentimes, professionals may assume that families would not have an interest, but many times they do. And remember, we are also a very diverse community. Families come in many different configurations, different backgrounds. And across the board, I have found great interest in understanding how information is collected, how it's utilized to inform policy and practice. And families having a voice in that has been very, very important to us. In New Jersey, we have multiple ways in which families have access to information and give input. One is, as Liz mentioned, through the Children's Interagency Coordinating Council. Now, we know that there's in each county or vicinage in New Jersey, there's a mobile response and stabilization program, there's a care management organization, and there's a family support organization. But often not talked about is the role of the Children's Interagency Coordinating Council, which is a very influential body that has the opportunity to share information and receive feedback directly from families. Because the CIAC is made up of all of the system partners and the providers who offer services to youth and families. So what better place to infuse the youth and family voice, but right there at the table where conversations are being held about utilization and about authorizations and about access and waiting lists and the demographics, which we've seen how that shifted over time. So the Children's Interagency Coordinating Council, called the CIAC, is really central in the work that we do. Families are engaged in a number of ways. They can serve on subcommittees of the CIAC. Here in our local community, we have a family voice subcommittee that is made up almost entirely of parents who have had the experience of utilizing the services and give feedback. We also have an educational subcommittee that includes system partners and some parents, again, who give feedback on how the system is working and how the system is operating. And those two committees are also joined by the Intellectual and Developmental Disabilities Subcommittee, which is a place where we share data regularly about the requests for services, the types of needs families are presenting with. And one of the most significant things was the difficulties that families have accessing the services and supports that they need, as well as the difficulty they have with understanding the process of applying for DD eligibility. As many of you may know, when you give birth to a child with a developmental disability, that's a diagnosis, but that is not the same as being determined eligible for services. And that was very hard for parents to wrap their heads around. So sharing data with that group on a quarterly basis, which is when we meet, has been really valuable in helping families to understand and to partner with agencies more effectively around accessing services and supports. Stop there.
Yeah, Hazelyn, that's very helpful. And I think it's so important for us to understand that there are systems and systems of care that are really built on this idea of New Jersey being one of them, by the way, that understands that the role of parents at the table as meaningful partners in policy development and helping to organize where resources go is a really important part of systems transformation. And that the New Jersey, right, this idea of the CIACs, right, the Children's Interagency Coordinating Councils, building a dashboard that really went out to communities, right? This is the whole premise of the CIAC data dashboard. And for folks who are listening, what's important to know about this particular document, number one is it's public. It's published on a monthly basis to the DCF, New Jersey DCF website, which I'll share a link, at the end of the PowerPoint for all of you when you're looking later. There'll be a link to it. But what's important about the dashboard is that it's not just the statewide dashboard. It's also developed for each individual county to be able to review whether or not there's, as an example, that you're getting to all of the children that you think you should be getting to, right? This was really important, Hazelyn, remember, on our work in integrating young people with intellectual and developmental disabilities, because what we realized is that we had real challenges in our system around access, right? Access was really challenging for families, and when we started to look at the data that said this is the number of children who are eligible within a particular community, we realized that the wealthier communities where parents had access to lawyers were more likely to have access to services and to be determined eligible. So it really forced us to think about how we were going to reorganize the system. But this data dashboard was the beginning part of that work. And so I think it's just really important for folks to know how these two things go hand in hand, right?
Absolutely.
Is anything on that data dashboard? Well, there's a lot of information, by the way. It's about 5 pages of information around, including information around, what kind of services young people are, utilizing, like residential interventions like group home, residential treatment, psychiatric residential treatment, how many young people have been determined eligible for intellectual and developmental disability services, who's getting respite summer camp, and even the substance that young people are reporting on their individual assessments. So it's a pretty cool tool for folks to take a look at.
It certainly is rich with data. One of the things that I like to share with families is the authorizations relative to the demand. And we can see over time, there's been an improvement in, the number of services that are authorized for families in our community based on some of the some of it is also about them knowing, families knowing what's available. And as we've worked through the kayak, through the educational subcommittee, and through some of the other community outreach activities, families have become more aware of what's available to them and how to access it. And we see that reflected in the data in terms of authorizations. So that's been an example of how important it is to share this information and then do a deeper dive on what might this mean and how can we work together, both the families or the family-run organizations, parent groups, and the providers to impact the service delivery system.
That's right. And one last comment on the dashboard, and that is, this is a tool that was really helpful for the kayaks to figure out how to apply pressure to the children's systemic care. And to me, in general, as assistant commissioner, to ensure resources were delivered in the places that they really needed to go. So it was a really helpful tool in being able to engage and understand what was going on the ground and be able to get real-time feedback on what was happening. So thank you for you know, talking about the Interagency Coordinating Council's work. Kelly and Sarah, we talked about data just from one particular perspective, but we would love to hear all of the work that you've done in Connecticut around this. So if you want to take a minute to say hello, and we'll get started on your slide.
Yeah, absolutely. We would love to tell you about it. So we are very happy to be here today. So I am Kelly Randall. I'm the Director of Quality Improvement at the Child Health and Development Institute. So we are located in Farmington, Connecticut. We're an independent nonprofit focused on child behavioral health and well-being. So we really function as an intermediary organization or a bridging organization between funders and state and federal partners and direct service providers to improve systems, policy, and practice. And one of our functions is we do serve as the Performance Improvement Center for the state's Youth Mobile Crisis Service. And that's what we're going to be diving into a lot of details on today. And I'll let Sarah introduce herself.
Well, hi, my name is Sarah Becker, as you can see, and I am also here in Connecticut. And I've done a fair amount of things, but the reason I'm here today is I've been involved with the Youth Mobile Crisis System in Connecticut actually since 1999. And was part of a lot of what we're going to talk today about, which is the real transformation of the youth crisis system in about 2010, 2011 to what it is today. And we'll be showing you a little bit about that. But that's my lens, and I've been working with CHDI and the Department of Children and Families for, you know, just a very long time to have the most successful system we can. Oh, okay, and I get to take the first slide here. So this is just like a teeny bit of a snippet about how the Connecticut's mobile crisis system works. So we are a system where we're hoping to have extremely rapid access to families at the time they need it and when they need it. And we in Connecticut, every single town, every single county has access to mobile crisis services. And we provide a timely response within 45 minutes. It's pretty quick. And then we do the rapid assessment, and we can stay open for up to 6 weeks to continue to provide ongoing care to families, either until their primary needs have been met as they are defining it, or until they're linked to the services that are most appropriate to them. The way the model works is, I don't know if you can see my little pointer here, but the referrals come in from really anywhere that a kid is. The top referral sources, as I'm sure is the same in New Jersey and other states, are families in their homes or apartments, wherever they are, shelters, wherever they are resting their heads at night. Schools, and then emergency departments. And the emergency department piece of it is really key. Those are when kids are referred there perhaps unnecessarily, or that they could be discharged back home. There's a real push on linking to mobile crisis services so we can help to stabilize that kid at home and hopefully not have them come back in again. All referrals are made to one number. In our state, it's to 211, and there's a way to 211, press 1, it gets you right into youth mobile crisis lines. They take a triage, and it's the same way every time so that families can expect what's going to happen. There's no sort of surprises when that happens. Then they refer out to a number of providers. There's actually 6 major providers in Connecticut, and they might have some satellite sites. And the only way you can be an MRSS provider in Connecticut is if there's many things you have to do, but you have to be within 45 minutes, any single town, region, area in your geographical region, so that we can meet response time consistently. So the referral is made to us, and as you can see, we get, and then this is looking at a car to get to where the family is. We actually have providers who take buses, subways, bike. I mean, it really depends, but for folks in urban environments, as anybody's tried to drive in some of our urban environments, it's like it takes a lot of time, and sometimes it's quicker to get there by the subway. So it can be in any way that's helpful. We are funded by the Department of Children and Families, and although we also are able to bill Medicaid and other insurance companies, but the primary funding is by DCF. They oversee us. They've helped to develop us. And then the Performance Improvement Center, as Kelly was mentioning, is through the CHDI, and they help to oversee all sorts of things about making sure that we have a trained workforce, making sure that families predominantly, they're our most important folks in this, that they're served well, and that the model's being, done as we intended it to be done. And then the next slide, thank you, Liz.
One question before
sure.
you go to the next slide, because I think it might be helpful for folks. Right now you're using 211. Is that going to be replaced in Connecticut 980?
Ooh, that's a
Or is that more complicated? We get to it later.
well, it's complicated all across the country. I think, of course, actually Connecticut right now is holding on to the no wrong door. 211+1+1 is so out there. I mean, you could look at a bus and there's the sign to get into youth. It's just everywhere. And because they're both managed, 988 and the MRSS call centers, both by the same group of people at 211, there's a little bit of a back and forth there, but the idea eventually would be if you call 988 or 211+1+1, you're gonna get to where you need to go for youth mobile crisis.
Wonderful, thank you. And let me move you on.
Okay. Okay, so this is sort of where we are at, and I imagine a lot of folks are sort of at this place. So back in about 2010 or so, like it really was a process. There was thinking around 2009, 2010, and then we got the whole thing up and running around December-ish, I think, of 2010. But so at that time, families, first of all, there were many, many providers. Every provider had their own phone number, and every provider with their own phone number operated with slightly different mobile hours. Okay. And then within that, the families, depending on what agency they happened to call, would get a very different response. With some folks in maybe one town receiving almost always a telephonic response, and other providers providing more of a mobile response. But in any case, it was just very variable, very varied. And then we had the situation where families who to me, again, are the most important audience, but it could be anybody, they're calling, and it's almost like a perception of you have to jump through hoops to get the service that you need. So it was like, well, wait a minute, if you're in too much of a crisis, you should go to the emergency department. If you're not in enough crisis, well, then you don't really need us to come out, and there's really not that much going on, so we'll manage this over the phone. If you have another treatment provider, you should be contacting them if you're in crisis. So there were so many like hoops that it ended up, and in the long shot, that many families didn't get what they needed. There is also the situation just around data, that people the providers would fill out their data, and it was sort of often handwritten, or there was like a spreadsheet we had to check, how many of this and how many of that, and send it in. But it really disappeared for the most part into like a black hole. It just was like, well, what happened to it? And there was very little output to say, well, is the service working? Are families being served well? And are providers doing what they're supposed to do? So that was a little bit about our world that we were in. So next slide, please. Great. So there was a redesign, and the process, as I was mentioning, took some time. And it was really driven by, well, yes, the Department of Children and Families, but also with parent advocacy groups, which were, I'm sure they're more developed in some parts of the country or some states, but was also very well established in Connecticut. And through like oversight councils and so on. But what happened was like, it seemed like 100 different focus groups, like focus group after focus group, trying to understand what went well, what wasn't going well, what needed to improve, and those types of things. So first it was like, what do we want? Also, Connecticut did what many of you guys are doing, which is like looking around the country, like what was working, what models, should we be looking at, what goals and values do we want to bring into our system? So there is a process. And eventually, sort of a new model was born with various things that went along with it. The goals were a whole bunch of increasing this and decreasing that and improving this. So things like increasing the number of referrals, well, that would be helpful. Increasing the number of times that a parent, when they called, or anybody when they called, would have a mobile response. Decreasing the amount of time it took to get to the parents. What else? So here's a big decrease in my book, decreasing the number of children who were referred to emergency departments. Sometimes because families and schools had no other idea what to do, but sometimes inappropriately and so on. So to decrease those numbers, to decrease the numbers of kids who are getting arrested or, landing up in a JJ world or lockup because of sort of behavioral challenges. So there were just, many, many goals that went on at the same time. And what ended up resulting is, as you can see, we ended up with 6 geographical areas. There was everything became standardized. There was no longer optional when you're mobile, when you're not mobile. You are mobile within certain parameters. And other things that were key at that time were the development of that centralized call center. So no more like 15 different numbers. It's 211 press 1 press 1. The Performance Improvement Center came on board. All of this happened like in 1 month, which all of these were game changers. Truly, like in a 1-year period, the volume of families and referrers in general that came into the Connecticut system it doubled, just like that. I mean, pretty much like within a 14-month period, that it was just a doubling of everything. But another key part of this is that there was the implementation of a data management system. And there was a lot of work that went into designing that. But the upshot of it is, and this is actually for every child service in Connecticut that's connected to DCF, but the upshot of it with MRSS is that the call center entered data as they got it. It was immediately available to providers to be able to pick it up. The providers then were able to enter what they needed to enter about a whole bunch of things. And then they wrapped up care, and then it went in a de-identified way over to CHDI as the Performance Improvement Center to be able to look at the data and use it to improve care. Long story short on that. So lots of game changers. And the next slide. Oh, I don't know. So Liz, you'll monitor that. Okay, Ms. Kelly.
All right. So yeah, I wanted to share a little bit more about the Performance Improvement Center before we start diving into some of the examples. So I think essentially one of the big functions was to avoid that data black hole, Sarah, that you were talking about. So, I mean, really focused on the aspects of quality. So getting regular feedback, having a standardized training and making sure those trainings are available to the workforce, but really making sure we're taking the data out of that system that you were talking about and being able to turn it around into timely, actionable reports that go back into the system and that are usable. And so kind of having some standard routine reports, which we're going to share some of the examples of how we use that. Also kind of doing those consultation site visits with providers to go over the data and look at how things are going. And then using the metrics. So we'll kind of focus on call volume, mobility, and responsiveness. And I think those are some of the key ones and some of the early ones, but I think things have also grown a lot. I know, providers are able to do more with their data and dig in and look at other things. And then, we've also been able to look at some additional aspects of the service. respond to ad hoc requests when we get them, and really learn as we've evolved. One thing that I think there are a few things that have been really key about making the Performance Improvement Center work was there is a pretty strong culture of partnership between the state, the providers, and the Performance Improvement Center. But also the reports that we make as Performance Improvement Center, they are, transparent, they're non-blind. You see the agency names and their performance, and they're posted and available. So anyone can go to our website and see the mobile crisis reports kind of going back to the beginning.
Yep.
And so I think why we're excited about data and here to have this conversation today is we know that it's important. Like when you measure something, that's what it starts to change. So just the act of knowing what is happening and getting that feedback is going to change the behavior. And it also allows you to know whether or not you're successful. And if you know you're successful, data will also let you demonstrate that to others. So we talk about data at multiple levels, so both the child and family level. What are we collecting for children and families and their situations? For the program level, for performance, how are things going at agencies or providers? And then also the need to have data on that system level, especially as we're talking about some of those longer term outcomes. What type of data do we get that can let us know, is the system improving because of the availability of MRSS services? So we get data from all of these that can be targets for the continuous quality improvement work that we do. And we organize it around it for this conversation and kind of how we're thinking about it: access, quality, outcomes, and equity. And the next slide has a visual on how some of the key questions that we're answering fit into that framework. So access, largely thinking about who is using the service, how often is it being used? So both like who is receiving services, who are the referral sources, who's calling in, what does that episode volume look like? What are some of the trends? So that's one that we're monitoring. Quality, really measuring anything that is going to mean that the service is delivered in such a way that outcomes are going to be improved. For us, a lot of time we're talking about mobility rate. So having, that face-to-face in-person response, 90% of the time, having that be the mindset, and then response time. So getting there in under 45 minutes. Outcomes, kind of, are families and children better off? Are they staying in their homes, in their schools, in their communities? Are they getting connected to the care that they need? And then also those system level outcomes. Are we seeing, fewer children ending up in the ED? Are we able to divert from the juvenile justice system? And along all three of those dimensions, making sure we're looking at it from an equity perspective and recognizing that you can be meeting the targets for access, for quality, for outcomes, but if those aren't being met for all groups, then that's kind of not good enough. So reporting, timely and actionable. We try for near real time. Does take a bit to turn it around, but I think that's one thing that we're increasingly working on, making sure that we can get data in the hands of providers. I think we said compare across regions. That's always been a key feature, that we're looking at it broken out by regions. And then that data is really used as we're working with sites on some of these cycles, like the plan, do, check, act cycles, and making sure that we're using the data to drive the decision making and try things out to improve services.
Hey, Kelly, quick question.
Yep.
Are you able to share the link for your historical data and reports?
Absolutely. I will do that.
Maybe we can embed it in the PowerPoint as it goes out. That'd be really,
Yeah, that would be good.
Yep.
One of the questions in the box. Okay, cool.
Yeah.
Here we go.
All right, so I think our goal is to give you some examples of the things that we look at, both as like an overall monitoring level where we are and tell the story, but also in some places pulled out just some examples to show kind of how we use the data, and a few examples of like stories of how the data informs practice and vice versa sometimes. So like we said, one of the main things is access. So measuring kind of call and episode volume over time. So this one just kind of shows that for Connecticut system. I think that there's like a pretty clear story you can tell at the end of the graph when we had COVID happen and seeing some of that reduction, but we just got those fiscal year 22 numbers in and added it here, and really starting to see that come back.
And what isn't shown here is the year before 2000, before fiscal year 2011. And that's where I was referring to, that the number of referrals basically truly doubled from one year to the next. So I can't remember, it was 5,000 mobile episodes of care, because providers were collecting it, but it didn't go into this nice fancy data system. So I believe it was 5,000 mobile episodes. So if you can see right there, bink, it just really took off.
Yeah.
So Sarah, and we could talk about this later, but I think it's important for folks to know that startup was what, moved in a particular direction, because I think that's what a lot of folks are really interested in is how does that work in the beginning, right? Do you go from 0 to, to 20,000, or do you go from 0 to 2,500 to then 5,000 and then 10, right?
Well,
so
it might,
yeah, go ahead.
Well, it might fit a little into another slide, but I think the important, so for us to, you remember I said I started in 1999, and we see 2011 here. So youth mobile crisis has existed in Connecticut like a long, fairly long time. And there was obviously a slow growing and so on, but nonetheless, about a decade ago, we said, we got to change this up. And it was really those changes that propelled, I think, all of the rest of this. But yes, if you're first starting out, it's like how to project. Okay, like we are first starting out. What is realistic? Should we be seeing 3 kids per 1,000 in my area? Should we then shoot for, in 5 years, maybe it'll be 9 kids per 1,000? So it is a process, and it's a building. Which, yeah, you're right. It could be a whole nother conversation, but that's like an initial response, perhaps, if it's helpful.
Thank you. Yep, absolutely. There you go, Kelly.
Yeah. And so these are just kind of different ways that we're looking at access. So this is kind of the map of all of the cities and towns in Connecticut, with just a sense of their service reach rate, how many episodes per 1,000 children are in the area. So the darker the color, the higher that service reach rate is. And that's also something that is in our regular reporting, and something that we are feeding back to providers. So whenever you see those graphs that have the different colors, like the purple, the blue, red, that really represents one of those reports that goes out that has all of the providers information together in one place. And then we're kind of seeing where are they relative to one another, relative to the benchmark, relative to statewide. So that gives a sense of where we are kind of across regions. Also thinking about different subgroups, so race and ethnicity. We know that there are more Black and Hispanic youth served by mobile crisis compared to the overall Connecticut child population. We tried to look at things, by race, ethnicity, by age, by sex, and then some of the intersections between all of those. And so we don't typically see differences across race and ethnic groups for numbers of males and females, but we do see a pretty consistent trend across race and ethnicity groups for males and females in terms of age, with males being much more likely to be on the younger side. So if they're younger kids coming in, they're much more likely to be male regardless of race or ethnicity. And then for female youth, those really start to spike later on. So kind of starting to see that increase around like 10, 11 and into the adolescent years. And then one other key part of access is looking at the referral sources and who's actually the person that is calling in and requesting services. So again, this one's going back to fiscal year 11 when we have relatively good data from that system, and looking at some of the changes over time. And so you see that, schools in between like fiscal year 16 and 17 overtakes self and family as a referral source, probably for a lot of concerted effort and outreach to schools to have them use 211 and mobile crisis instead of other services. Obviously a big dip in schools around COVID, and then seeing that come back. And the ED, we're going to talk in a little bit more detail later, but I think that's one of the things that kind of drives us, especially around that redesign time when, you know, the children in the ED rates were going up and like the mobile crisis episodes weren't necessarily matching that. So kind of having that as a key function. So even though they're, you know, around, you know, between 10 and 14% of referrals, knowing that that's an extremely important referral source that we monitor. We look at referral source, again, by race, ethnicity, age, sex to look for trends. And I mean, one of the things that we do know is that for Black youth, Hispanic youth, youth from another race, they are less likely to be self-family referred compared to white youth. They're slightly more likely to be referred by schools than white youth.
Keely, do we have a sense of why that is?
I mean, I think that that's probably a lot of factors, and it's one of the things that we don't have, you know, a good sense of. I mean, kind of getting the calls that we get from the referrers that we get, but it is a pretty clear trend, and it is one that I feel like is sometimes a little bit harder to make sense of, especially when we're talking about schools. And I think there's been a lot of effort to, you know, we know they can disproportionately call the police on certain groups. So when we see kind of that trend in the mobile crisis calls, it's like, well, that's good if it's being used instead of, you know, more intensive or less desirable options. But yeah, we definitely see like that higher rate from school and then lower for self-family, which I imagine has a little bit to do with just general like trust and outreach and connection to systems potentially. But yeah, I think that trying to get a more nuanced view of that is one of the things we are kind of chipping away at and using this data.
Yeah, and I think it's one of those things that there's this statewide, all these hypotheses, and then on the provider level, and you know, when they're, you know, you test them out and see what, you know, what's going to help what. On the provider level, when we all also have things that we want to improve on, we work with CHDI to set some goals and test things out. So that's one of those areas that providers have also tried to look at on the local level as to what could be influencing what and how to help things. Oh, is this my slide, Kelly?
It is.
So, and actually just someone was just asking about, do you have something on presenting problems? And this is one of these we can also, it's broken down also by ages and races and ethnicities. And we can really see some proportional types of differences between the populations. And this one's really focusing on, looks like race and ethnicity predominantly. And, you know, to mention, you can go on, we're going to get you the link, but you could just go onto the CHDI website, you click on like reports, EMPS, and you can see all of this annual reports and everything going back to literally, it feels like the beginning of time. But what we see here is, again, this difference. So that if you look at just the two left hand, so if you look at the blue and the yellow, which happens in this chart to be representing Black youth, Black and African-American youth, white Caucasian youth, that you see, well, this is kind of, it's different, right? So Black kids getting referred more. And this is, we have to remember the presenting problem is defined in this case by the referrer and what they're telling 211, who then gives a narrative over to the mobile crisis team, so that it's really in the eyes of the referral source for the most part on this particular thing, so that Black youth are referred. They're not for more often for disruptive behavior type of things in comparison, especially to, well, the two here between Black and white, but though now I'm looking at the purple. Oh, another race. And then if you go over to the harm, which is these two have sort of changed up over time, like is it disruptive behavior that's the #1 issue, or suicidality, self-harm, and so on. So they've a little bit changed up over time, but historically it was suicidality, self-harming as the #1 presenting concern. But in any case, you notice almost an inverse there, where Black kids were getting referred less often for the harm to self, which is kind of like, So then you sort of like, what's the hypothesis? Liz was just asking, is that, you know, are Black kids just maybe less depressed? Are they noticed more often for their behavior? The referral sources seeing the same disruptive behavior, the exact same thing across races, but saying one is because they have a behavioral challenge, somebody else, maybe it's trauma induced. So there's a lot of things that could go into this one hypothesis, but no matter what, this pattern has demonstrated itself for many, many, many years, this exact same thing here. So it gives some areas to like understand, to try to figure out what could we perhaps do about this. One of the things that gets me about this slide is I do some other training and have looked at, and I'm sure folks here can put the thing, put a link in this, but the ring the alarm, and then the next part of it has to do with Black youth and suicidality. With the #1 increasing population in terms of suicidality being Black youth, and especially our really young kids, you know, our 5 to 11-year-olds. So sort of like, are we missing this group of children, or could we do more to screen for, or identify, or that type of thing? So, I mean, anyway, so this is one example of how you can really start to use data to dig in a little bit and see about the service system.
Quick question, Sarah. There's a question in the chat around what the other means, right? Can you?
So let me see the tops. Okay. The other race. So this is often. Go ahead.
Oh, sorry. So is it, I think where we're saying the other is in the presenting problem type. So this one came from like a comparison. Yeah. Cause I was like, oh, we don't say other. So it's pulling out, it's kind of really comparing disruptive behavior, harm, risk of harm to self when we were doing some of the analysis, but the other would be kind of those other categories that are collapsed in the pie chart. So depression, anxiety, family conflict. Yeah. So those categories. For this one, we were kind of zooming in on the disruptive behavior and harm, risk of harm to self as one to highlight when we do all the comparisons. But yeah, that other category is kind of those other ones in the pie chart.
Yeah. And yes, focusing on those, but these also are the 2 #1 presenting concerns. So they really are making up the bulk of the referrals reasons.
Great, thank you. That's very helpful. And back to this conversation around, you know, the risk of harm, you know, are there places in which we can gather more information around that? This would be one of those examples that Hazelyn and I would take back to the Children's Interagency Coordinating Council and say, we really need to understand this. Like, what's really happening here with these young folks? How does that work in Connecticut?
Oh boy, Liz. I mean, I think what we're saying is like, we can see the trend. Kelly's saying we're sort of trying to, you know, dive into it deeper on one level. And then on the local-ish level, like, let's understand it. Is it the who's calling in?
Right.
Is it what they're seeing, what they're attributing? Are they dismissing groups of, you know, presenting, you know, like, I mean, so I think there's so much that can go into that. And then from there, like, if we really are thinking it's a matter of something like outreach, or for school staff, maybe a training on like how trauma looks, what does trauma look like? And is that really what we're seeing for certain populations versus, you know, this agitated state that often gets labeled as oppositionality or impulsivity?
Well, I was just curious because you have such capacity to be able to pull down data, to be able to see what's happening at a local level, right down into the, you know, into the zip code, right?
In school.
So that ability to then say, hey, how do we engage these schools, as an example, who might be, you know, not really identifying this risk of harm in a way that makes sense. And, you know, are they really paying attention to things like historical trauma, right?
Right.
As an example, those are the kind of questions.
Or yesterday's trauma.
Right.
It's like,
yes,
it'd be either one.
Right. That's totally right. So I was just curious whether or not, you know, but we'll talk a little bit more about that. And I'm sure folks might have some questions about that. Reminder for folks to just put questions in the chat, and we're happy to work to try and get you answers. All right, back on track, guys.
Back on track. Oh, I think we can change the slide. How's that? Okay, and this is one of these, actually, I think this is Hazelden, where I was like, oh, go Hazelden in the beginning, if I've said that correctly, because this is like, all right, now here's an example of it all playing out potentially on the local level with the questions that we're asking. And then what is it showing? Is there something we could do to have different outcomes? Or to, if that's whatever type of outcome you might want to have. So in this example, you remember there was a little slide that talked about service reach rate, the number of children per 1,000 that were being served in any given region. And one of the regions there showed higher by 1 standard deviation over the average rate than anybody else. So a very high service reach rate, not the highest population, but the deepest penetrated, if that's the right word, into the community. Okay, so that's good, I think. I mean, many people are being served. That being said, within that same region, you could look across the percentages for the referral sources and say, this is kind of interesting that the family, that less of a percentage in comparison to state average are being referred by families. Okay, and that's kind of makes sense also in that the state's largest emergency department volume-wise for kids is like it's right there smack dab in the middle, and they have a lot of emergency department referrals. But nonetheless, it was lower than other parts of the state. So then it's sort of like, is that a concern? Why might that be? So there's hypotheses that get going. But this was sort of some time ago when we said, well, geez, what is the perception of mobile crisis? Do people understand how it works? Are there concerns? Are there barriers? What might there be? So the local area actually partnered up with 2 family advocacy organizations. One, and of course, they would serve anybody, but one was specifically involved with the African and Caribbean American folks, and one was more working with Hispanic folks. Primarily in this city, there was a big population of Puerto Rican folks. So each were partnered with Mobile, and there was a dedicated outreach effort by the advocacy organizations, by folks who are typically, representative of the populations they're doing outreach to. So it was seen as pretty successful. And so it's just an example of using data, seeing it, not just taking it on its face, like, that's great. We have a very high service reach rate, but we were concerned about the decrease or less of parents and families referring.
Yeah, and I think that's a good example of, the providers looking at their data and identifying things and making plans to, by themselves. Yes. So using the reports, but like very quickly, I feel like, a lot of times they're leading the way and figuring out what is the next step, how can we improve things, in partnership with the Performance Improvement Center, but driven by them.
I should have said a key part about the data management system is it is pull downable at any given time by the providers. Anything you want to look at, whether it's race, the time of day, the presenting problem, whatever it is, I can get on. I'm no longer in the provider world, but still I could get on at any given time, pull out exactly what I was looking for, and do my own studies, my own reports, and did things help over time. So that's a cool part about the feature, about the system.
All right, so this is kind of a look at ED referrals, just as another example of how we're kind of using the data and then changing the data. So when we're looking at ED referrals to mobile crisis over time, seeing a little bit of a dip. I think during the pandemic, we saw a spike up. And that was also an increase in the total number, not just because schools fell off as a referral source. So like that obviously changed the percentage, but also there was an increase. And then, so kind of using that to look at, okay, providers here is who are the hospitals that are calling, where are they coming in from? So the map was kind of looking at the hospitals and kind of mapping it onto the number of cases that were called. And then one of the things that came out of that was that a lot of the time when the EDs are calling mobile crisis, the child was sent there from the school, and that was an important piece of information, and we really had no way to collect that. So that was where we like changed the data system. And now it is, if an ED is calling, it's like, all right, well, was the child sent there from a school? If so, what school? And so then that's like a piece of information that can be given back to the provider and get a sense of, okay, where are the schools that are calling the ED when they do not have to? So mobility, so we talked about access, mobility is a big one. So here kind of the similar, starting with that overall statewide mobility rate over time. And so this is a calculation that has been adjusted. So you kind of see two lines, both where it was looking historically under the two different calculations. So it was changed a little while back because often there were instances where a school or an ED was calling for a child or family without necessarily having the child or family there or seeking services. So, and then it would be really hard. Either the family did not want services or it was very hard to reach them. So we kind of look at it in both of those ways.
And again, there's the year before 2011. If you remember that very first slide, it said 50% mobility. So
Right.
It went from that to this just with having a standardized metric and way to measure it, in my
Right.
opinion.
Yeah, just kind of like measuring it changes the behavior in some ways. And yeah.
Because that data was shared and it's public and transparent so folks could see it, right?
Yeah.
Yeah. And so mobility rate, that's something that's looked at monthly. So I just pulled these just from some reports just to show what it looks like when it goes out. So again, like the different colors, that's like a report that goes out that anyone can see. It shows each provider in any given month what their mobility rate looks like. And then on a quarterly basis, kind of when you see like just the blue from this year that I pulled, those are the reports that really drive the site visits that the Performance Improvement Center does with the provider. So they're looking at, okay, here's your mobility rate over, you know, this quarter and the previous 4, what are some of the trends? And so those are given to the providers. They're looking at it, they kind of write about their story behind the baseline, like here's what we were seeing, here's how it looks like the same quarter from the previous year, here's how it looks from just the previous quarter, and they're kind of giving that information ahead of time to inform those quarterly conversations that are taking place around mobility. And then kind of a very similar thing here showing the data on response time. So the expectation is 45 minutes or less, and like 80% of the time that should be met. So you can kind of see how it's going. This one just ends at fiscal year 2021. So we'll add the 22 number as we're crunching it. But I think the story is, you know, that is consistently above the benchmark, but that is one that has been increasingly challenging, I think, over the past year and probably in fiscal year 22 as well, with some of the workforce challenges. So that is, I think, where a lot of the conversations are, and providers are figuring out how to, you know, meet these benchmarks and be responsive when they really are pretty short-staffed.
Just laughing. It's like, you know, I mean, as an example for that, a team that I oversaw had 24 clinicians and other staff, but just speaking on the who can respond, chopped down to 8 in a given year. So like, yeah. I mean, we're getting close, but I mean, you can see at a certain point in time with the highest volume region, I mean, it does get tricky. Yeah. So, oh, and
this one was just, it was just another example of, you know, like monthly, you have the different colors, we're looking at each agency, and then quarterly, we're sitting down and having a conversation, doing a deeper dive into their data. And then the next one is you, Sarah.
Is it I think we skipped one, Liz, or am I on this one? Your
discharge reason, or no?
Okay, so we did this one with the response time. And then, okay, so this is, we're going to break it down by race and ethnicity in just a second here, but this is the predominant. So we have like, why did folks discharge? And you can see that most people and most families state that they have met their own goals that they've set for themselves for the mobile episode of care. And so that's a good thing. And then you can see some of the other things. So that's good, but about 11% of the families discontinue themselves, which is okay. That's good for families. If they don't feel like it's helpful anymore, need it anymore, that could be a good thing. But it's also looking at why did they discontinue, and is there something that's of concern in that? And there possibly could be. So it's just, again, thinking about the data, and that's that's the statewide reasons. And this is another one that's sort of, okay, it's the same graph in essence, but broken down by race and ethnicity. And this is another one of these, like it's just different. So if we certainly want people to and families to complete treatment, no doubt about it. And the majority of families do in a way that, feels, I think, good, and they feel helped by the service. The satisfaction surveys are very high, those types of things. But we do, again, have, again, you could look across the board, but here we have our Black youth and Black families stating that that they're not meeting their goals. They haven't completed treatment at a pretty big difference between Black and white kids, but you can see it across the board that there's a variation with typically white folks experiencing more of a success and that they have met their treatment goals as a response to mobile, being involved with this service. So lots of things, again, you can hypothesize and, think about it. Does it have to do with perceptions of like getting help, depending on just in and of itself? Well, that's a pretty big one. Does it have to do with the number and type of follow-up care that was offered to different families? That could be the case. Does it have to do with the lack of differences in engagement abilities, depending on who the clinician is and who the families are? I mean, it could have to do with a lot of things, but it's certainly something to really study up on, know, and figure out, get some ideas about what could be helpful in that. That to me is one of those concerning ones.
And I have a quick question on this. Is this who makes the decision on whether or not they completed treatment? Like whose decision?
Well, you're correct. I mean, best practice would say it's always the family, right? Who states themselves. But there isn't like a set. How would you state this is? Do you feel like it's not that direct? So ultimately it's filled out by providers, though then there's satisfaction surveys and that type of thing that are also speaking directly with families.
Okay, thank you.
All right, so I think everything that we went over was largely focused on a lot of our regular reporting and the things that we're looking at consistently, monthly, quarterly, annually. And I will quickly go through, because I know we want to get to conversation, some of the places that we're going and the things that we are starting to do that is maybe a little bit new, or kind of redoing some things that we've done. So one thing that we mentioned is that, a lot of these behavioral health services, if they're, funded by DCF, they are in that same data system, the data system that 211 is putting into, that the mobile crisis providers are. And so, outpatient services is, a third of children are referred there. And, you can link through identifiers, to that outpatient data if they're at one of the OPCC clinics. So that is one of the things that we are just starting to do, is make that match so that we can start to say, okay, they had a mobile crisis episode, they were referred to outpatient. Did they show up to outpatient? Are there differences in who ends up getting a connection to outpatient versus not? When they get to outpatient, how are they doing? So that is one of the things that we are starting and are excited to take a look at, to kind of link across those services. The next one that kind of recently came out from some of our staff here at CHDI was looking at multiple episodes. So we know that there are multiple episodes. We kind of track that within like quarters, but never really looking at patterns over time. So if you follow kind of like a cohort of youth, what are the factors that are predictive of a child or family having multiple episodes in mobile crisis over a period of time? So, we found age, female. I mean, you can kind of see here that it does each one of the ones, and there is paper we can, obviously talk a little bit more about that, but that's one of the things that we're trying to dig into to, in addition to those regular reports, what can we really say with a wider scope over time about children that are coming into mobile crisis repeatedly, and do those trends kind of map on to some of the trends that we've seen in children that repeatedly are going to the ED, because we had some of that data to compare to. This highlights one look from fiscal year 18, trying to put a dollar amount on mobile crisis diversion from inpatient hospitalization. So I won't walk through all of the figures here for you, because I know you can see them, but really kind of looking at, the the average cost of a mobile crisis episode, and then within a mobile crisis episode, when it was indicated as having been a diversion from inpatient hospitalization. So that's something that's indicated within the episode. And so when you kind of find that number of, what an inpatient episode would have cost compared to what the mobile crisis average episode costs, and kind of do some of those calculations, you get to like a pretty big number with a relatively small number of the overall mobile crisis cases.
That's true.
So wanting to do kind of digging into that and refreshing those numbers, I think is something that is on the horizon.
Well, that's good news, because I think this is one of those slides that most states are really interested in.
Yes. Yeah. So I think that is definitely one of the things that really there is a lot of interest in and a need to relook at it, and trying to see, is there any way we can quantify ED diversions, like in some of the other pieces of it. And then talking about ED diversions, this was a study that found, matching up with Medicaid and some commercial claims data, finding that mobile crisis use was associated with a 25% reduction in ED utilization. So kind of that one stopped short of putting the dollar amount on it, because like figuring out what those would be. But I think kind of going in that same line of what we were talking about before, if you can get there and you start to make those calculations of, okay, yes, what does it cost to have a mobile crisis episode, and what do we know about them being, diverted from inpatient, or 25% less likely to end up in the ED over the next 18 months, and kind of build out the cost information.
Hey, Kelly, we have a question in the chat. Chelsea wants to know, how was the diversion identified or defined to get that number? So
for the inpatient, I mean, that's something that is like entered as part of the episode. I mean, Sarah, you can correct me if I'm wrong, but I think when we're talking about like, is it a diversion from the ED? That's a factor that we get from like the clinician's perspective. If they feel like that was an episode that would have been, the ED diversion was looking at the actual, did they show up in an ED using the claims data for the 18 months? So those are the two different ones.
Yeah, it was a really, I have feelings about this metric, just to be said about it. But so that was it an inpatient diversion is determined by how the ED code in essence said what they say to 211. So they're saying, yep, they would have gone inpatient, but for a mobile crisis. And the other one is that they could say, nope, it's what they call routine follow-up. So I'm like, So what we've also seen in the data, though, is that one hospital with a number of referrals to one emergency department with a number of referrals to MRSS codes, just about everything is an inpatient diversion. And another hospital would code the same type of thing much more often as a routine follow-up. So that's one of those good, we're not going to get into it here, but like the data dictionary, like how are you really going to define things? What makes what? So anyways, that's the best answer I can potentially give right now. A quick answer.
Thank you. That's helpful. Thank you.
Yeah, and so this is our last slide, and I think it just really reiterates some of the major themes that we've already talked about the importance of the partnership, kind of having those multi-agency meetings where the providers are coming together to talk and look at the data, meeting with agency leadership, kind of using the data in plans to improve, and then also using that to inform kind of the training curriculum and what's offered for training to the provider network.
And to say on the quarterly meetings that it's yes, CHDI and the providers, but every other quarter, I believe, it's our state contractors, state partners coming, out to the agencies. How is it going? How can we help you? It's not antagonistic, but it's that much of a partnership. It's just that embedded into everyday world of mobile crisis.
I want to actually dig into a little bit more about what those visits look like in a second, but there was a question in the chat that I wanted to make sure that we got to before I pulled the slides down. And that is, in a couple slides back, does physical aggression fall into harm or risk of harm to others or disruptive behavior? I can go back to the slide if you need, but the question came up after I saw it after we moved the slides, so I just wanted to see if there's a chance that you could explain that.
Yep, and this is one of these, you can see that we didn't talk about data dictionaries, but it gets there were more and more importance of it. So I would say that's really in the eye of the receiver. So, I mean, you know, who's taking the referral and passing it on? So there's someone be obvious, you know, he beat up his, you know, perhaps he beat up the whoever in the school cafeteria and he's really aggressive right now and he's saying, and so we would get called and off we go. And that would be, you know, more clear cut. Perhaps that's perhaps a risk of harm to others, but you're right that there's all these borderline types of things. Either one of them would be concerning to me if what was really underneath it was like a trauma, anxiety, depression type of presentation. But I guess I could say those would be, that's one of those crossovers, like which is which.
So really the question is, how do you put it in a data dictionary, if you will, so that you help those
Exact
who are
question.
trying to code these things, to code them in a way that's consistent across communities, right? I'm going to pull the slides down and maybe we can actually just talk a little bit more about what that data dictionary might look like for folks. So let's start there. Kelly and Sarah, do you have a data dictionary that allows folks to sort of, you know sort of how to code some of
Yeah, I would be, well, and Kelly, sorry, first of all, I dominated.
No, it's fine. So, I mean, there is a data dictionary in the data system. So, I mean, we call it PI. I mean, each one of those elements is defined and there's guidance on how you would answer it. But is there things that could be further clarified?
Yeah.
I'm sure. Yeah. You know, like, so Sarah, I didn't want to cut you off on what
you didn't. So, and I think that's probably, it could be even public. I'm not sure about that, but just, you know, as applying to, you know, like, here's an example. We want to get out there quickly. Okay. So, but when does that clock start? Does it start the exact second a parent calls? Does it at the exact at the time that I'm saying we're coming? Does it start really 10 minutes later when we've received a confirmation call back from somebody that something is going to happen? So that type of thing gets kind of hard to put into a data dictionary, but those are the type of examples that, like, let's get it really tight. If we want somebody to be there in 60 minutes, when does that clock start? Sure. And what does it mean on the other end? If did I drive into the parking lot? Oh, got there in 60 minutes. Mm-hmm. Is the, you know, providers feel docked when they're waiting at the front desk for the teacher, the social worker, or for the kid to be brought down, and they're waiting and they're waiting. Mm-hmm. Anyway, some providers would say nope, because we didn't see the kid yet. So they're waiting, and they're missing their response time. But it's an example of like how this very little thing could be thought through on many angles for a state. Like, how do you really want to, you know, go about this with giving input into it?
Sure. I'll just give you one example. So in New Jersey, the good news is that the single point of access, when they disengage, that's when the internal clock and the electronic record start, right? So
as does ours, as does others. Yep.
Right. But there's a lot of challenges in making sure that there's consistency in terms of practice and how all that works. Can we just talk real quick about, I think it's so really interesting how you do the connection with the providers around the actual data, right? And bringing that and talking it through with providers so that you can get to sort of some quality improvement strategies. And I'm going to guess that that's how you've really improved your data collection over time, is those really important conversations and partnerships. What does that look like?
Yeah, so obviously there's monthly meetings with all of the, the leaders of the agencies, and that's with the Performance Improvement Center and DCF, and then the quarterly site visits. So I shared like little pieces of the data reports that go out to the individual agencies, but those are, much longer and more comprehensive, kind of looking at each of their data points, looking at it over time, filling in a little bit of the story. And so those, I mean, if you really want the nuts and bolts of the process, like we have a project coordinator, she sends that out to the provider. They're looking at their data, and there's a section for each element that's called the story behind the baseline. They're filling that in. So if there was dips, if there was increases, they're really saying, this is what this is our story. This is what happened. Here's what you're seeing, not seeing. Sometimes they're pulling additional data to support kind of the story. Those get sent back to us. And oftentimes we sit down in preparation for the site visits. If that's one where we do have our state partner attending, we sit down, we read through all of those, with them before we're then going out. And so those used to be in-person site visits. Now they are virtual site visits, but then you're kind of having that quarterly meeting with that document that everyone has really touched and interacted with and processed, and kind of seeing where things are. And so sometimes if they're, if the challenges are around like mobility or response time, that's where the conversation is. Oftentimes it is, things are looking good. What else can we do, and what else can we dig into to kind of set the goal that we're working on for next time?
Yeah, that's really interesting. I think, and really impressive, right? To take the time to actually walk through what's in that data and data dashboard. I know, Hazelyn, I know that you probably want to weigh in on a few things, so I'm going to give you a minute to talk about. No, that's cool, right? A couple of things, but my first thought was how complicated it was when we just did a data dashboard just to the kayaks, and we took that data dashboard and held on to it for a year, where we actually met on a regular basis, talked through, is the data right? Does it make sense? Does this look like your community? Did we get that right? Making sure the data dictionary was right and that we're pulling from the right places. And so, but also, spending time with the kayaks to talk specifically about how do they actually talk about it, right? Like, how do they have conversations about it? How do they use it to interpret what's happening in their own communities, right? So, and I know Hazelyn went through that whole experience. So I'm going to give you a few minutes, Hazelyn, if you want to talk a little bit about that, and maybe some of your other thoughts as Kelly and Sarah presented such impressive work that's happening in Connecticut with some interesting data points.
Absolutely. I do have to say hats off to you folks, and what you're doing in Connecticut is phenomenal. I really was struck by the language that you used around creating a strong culture of partnership, because in order for us to make systemic change, that has to be one of the foundational elements. And I think you've demonstrated that in the information that you've shared today. For us in New Jersey, and my specific experience in northern New Jersey, which is a little different than other parts of the state, we're about 30 minutes outside of New York City. And so we're rather in the large metropolitan area. What we have seen is that the data really can drive and influence decision-making when we understand what the terms mean, and the nuances of the experiences that families are having. You shared some very interesting data around diversion, things to look at: diversion from the ER and diversion from juvenile justice involvement. One of the things I know that we've been interested in as a system partner is that very topic, and also looking at, is there a change in school suspension as a result of these interventions? And so we're hopeful that the data will point us in the direction of some potential strategies for addressing some of the challenges that we see. You also mentioned the report that recently was published about, and that highlights the epidemic of suicide among young Black children. And I just shared that report actually in the last 48 hours with our board of trustees. And
wow,
they are all parents, and some of them happen to be professionals in the education space. So we're very interested in having the conversations around why do we see these wide variances? And is it structural, or is it a matter that can be ameliorated by some of the professional development and training opportunities that we have been fortunate to have in New Jersey around trauma-informed care and the role of ACEs and so on? And a lot of that work, Liz was front and center at that in the early stages. So it's really impressive to see what you've done and to learn from you, and to also at the same time appreciate a lot of the great work that we've begun here, and you showing us how we can scaffold it to really influence policy. The last comment I would make is, it's really a question. I heard mention of the collaboration with a couple of the groups in Connecticut, specifically the family organizations, and the recognition that you have different families, right? You have different cultures within the same racial category. So as a Caribbean woman, that was of interest to me. And I was curious about how that partnership evolved, and any lessons learned from that you could share.
So there's the statewide partnership development, and then there's sort of the local level development. So both of these, okay. All right. So I mean, there's so much on the statewide level having to do with family advocacy, and like an organization called Favor, and they're at virtually every table around decisions, policy development, our oversight council for behavioral health. Like they're sort of kind of everywhere, and which is great. And actually the same people, like gosh, I was just joking with somebody from the AFCAM group that I met basically 20 years ago on the local level. I joke because he has size 17 shoes, I have size 6. It's a bad getup every time I see him. But we've been partners kind of forever. So, and they're very much part of the Hartford community and all of the like community collaboratives and that type of thing. And so within that, like actually, even when the redesign happened for mobile, there was actually basically a requirement. You need to be partnering with folks in your, predominant groups of all sorts within your local community. So that was like more of a formal memorandum of understanding type of thing. But I think the partnership is just really mostly on a grassroots. We value each other, both have strengths. We absolutely need, and family advocacy is the name of the game. So, but there was also like a fiscal thing that went on. So that's nice that the groups are there. It's great we have a partnership, but we're asking about a sustained, we're really asking for help. That's going to take a lot of hours and a lot of resources and that type of thing. So then there was the mobile folks, the agency reaching out and saying, geez, we really need help. So there was a financial arrangement also. Like in essence, they're not an employee, but we're subcontracting with them to help us out with a big need. Good. If that makes any sense.
Yeah, that does. Because oftentimes I think that family engagement may not realize the full potential because there's so many other things drawing families who are in need of services away from being involved in this systemic change or feedback on system improvement. So that's very helpful. Thank you.
Okay, I have another, actually more of a comment to make around the shared sort of understanding about these data points around younger boys, right, around the rising suicidal ideation and completion rates, and maybe trying to figure out how do we all come together to begin to try and figure that out. So I'm just going to put this out there that we should put our heads together in the aftermath and try to figure out if we can actually add on to one of our upcoming conversations around this concerning place for people in children's behavioral health who are worried about how do we actually do something to address this, and how do we use data to get us there. I just wanted to put that out there. The other thing I wanted to say about this the data set is, and when we talk about mobile response and stabilization, or mobile, crisis, and depending on where you are and what you do, when I think about it and I talk about it, it's really about meeting the sense of urgency with the sense of urgency. That is those response times and how we respond to parents, which is so powerful and important. But the other thing that we're really trying to do is interrupt, right, the movement to emergency departments, which you guys have done a really good job of capturing, inpatient care, which you've done a good job of capturing. Have you been able to capture data that takes you a little bit further down the line, that looks at things like residential and residential interventions and the impact of that within Connecticut over time, and the role of mobile in doing that? Is that something you've paid attention to? I can tell you that it was like, when I was the assistant commissioner in New Jersey, that like the residential number was the driver number on my desk, right? So it was, and I've said this before, I'm just gonna make this quick comment for mobile response folks, that as the children's behavioral health person in New Jersey and intellectual developmental disabilities and substance use, I was not worried about mobile teams doing what they needed to do, right, from a risk perspective, but I worried every day about residential, every day about inpatient care, every day about emergency departments in ways that I got gray hair, right? So I asked that question because part of what we say to folks is, hey, if we can get to families at the time when they are beginning to feel those experiences and feel that sense of urgency, it can impact on that longer view of residential. And I was just curious if you have taken a look at that.
Certainly have data. Kelly, how would you like to answer that?
You look at it, right?
Because there is a lot of data around it.
Yeah.
It's coming down the pike as well.
Yeah, no, I mean, I know that is certainly like one of the things that we're talking about, and how do you link this? I don't have anything specific around residential.
That's fair.
I have looked at, I know it's been a lot of the ED and then figuring out how, for some of the schools, but Sarah, you had something to say on residential?
Well, I understand, Liz, that every single day when you were in that hat, every day, you probably went to sleep at night. ED, inpatient residential, because we're trying to keep everybody out. So there was looking historically what happened in the past. See, it's hard to make a correlation quite off the bat. Like if you had 2 episodes of mobile response in the past 9 months, did that stop you from going to residential 6 months from now? I think it's a very hard thing to get at.
It is. It is.
With respect to that. So, we have a longer term study, but we do know that the residential in general in Connecticut, as with many places else, have sort of plummeted at the same time that community-based services, of which mobile response is like, I mean, there's many, like all of these in-home, all of that, but mobile response was a giant one. So it's at least happening at the same time. There is also, I meant to say about the school situation, by the way, that all MRSS teams in Connecticut have MOUs with the individual school systems in their counties. That was a little bit of a challenge, I'm just going to have you know, but we did it as a state. Every single, even the private schools we have MOUs with, so that was done. Okay, and mobile response does go out to group homes, which doesn't happen in every state. So with the exception of seeing kids on inpatient units and seeing kids on residential, anywhere else we could prevent or respond to, we do.
And that would impact on that stability, right? That ability for the young person to stay in the group home without going.
Let's hope. Yeah. And for foster homes, that's a big focus to prevent disruptions. And
yeah, absolutely. Listen, I know that we're getting ready to run out of time, but I do want to make one other data point, and I imagine all of you would agree with me that one of the really important parts of collecting and sharing and using data certainly is in the quality improvement world, but it's also really important in telling your story, right? And helping people be able to see progress and why these investments are so incredibly important. And what I know is that Connecticut has a really powerful mobile response and stabilization story because of the data that you've collected and your ability to tell the story over time. it's not insignificant that you've published reports and done a lot of work around emergency department visits and around inpatient care. Those things are really powerful tools in helping to tell the story. So I, for one, am incredibly grateful for all of the work that you've done in Connecticut and continue to do. But for the group, I want folks to actually take a look at and pay attention to the ability to tell the story, right? And to tell how Connecticut has told its story in such a powerful way, how New Jersey has worked to tell its story as well. I'm going to give you just a minute, each of you, if you have any comments or things you want to share with this group as parting words of wisdom, since you're such a smart and such a skilled group. So let's start with you, Sarah.
I think, and Hazelyn, I'm not sure if I said your name correctly.
Beautifully.
Oh, we did. Okay, that's good.
Thank
I think if it was for me, so like back in the day, there was a lot of anxiety about, what do you mean the state and the CHDI folks are going to come out and sit with me in a conference room, you know, every quarter or whatever it is. What do you mean there's going to be, my data is going to be compared to every other agency's? And not only that, legislators can see it, like, dun, da, da, da. This is how so there was so much anxiety, but almost instant, like within just a few months of the data collection and the data sharing starting, there was just much more of a level of comfort. It is a partnership with us informing each other, right? So and Kelly mentioned it, sometimes we're helping CHDI to see something differently. Sometimes CHDI is helping us. So it's just that, it's collaborative, it's quality improvement oriented. I think we have a good team spirit in Connecticut to improve things in general for children and families. So I'll say that. I would also say we in Connecticut learn from every other state. I mean, like, right, because we all want to improve. So maybe somebody will take something away from Connecticut, but at the same time, we're learning from everybody else.
Thank you, Sarah. How about you, Kelly?
Yeah, so I mean, I would say that I would agree that kind of that culture that we have and of partnering and the buy-in to the data and how open people are. I mean, that's really what makes it work well, but it's not that it was like seamlessly easy to get there. And I'm sure people know that even better than I do. So I think that that's very powerful. But I do think even as we're talking about what we've done, kind of just seeing like ways that we can improve, like I've jotted down kind of that more public facing dashboard, you know, like, yes, you can have the reports, but is there a way to even innovate further so people can access it in a different way, or having even the data dictionaries available for kind of families and things. So I think that, you know, in addition to some of the directions we're going and kind of some of the matching and trying to get better numbers on if you can follow children after their mobile crisis episode, I think there's also, you know, ways to innovate to make the data even more accessible in ways we could continue that. So thank you.
That's really great. Thank you.
And I'll just show you guys while you ask the link. So here I am sitting in some random training. I put in you know, in an important one, but I'm just saying how easy this is to do. The CHDA website, I go to reports, I pull that down. Mobile crisis reports. You can press on it and it's, you know, it's literally right there going back to the beginning of time. So anybody today could do that if you would like.
Thank you. Hazelyn, take us home.
Okay, so I really leave today's discussion very heartened by the potential that we have to really use data in effective and creative ways, and even more so to include and to elevate family and youth involvement in these conversations. And for me, the word that resonates in my mind right now is intentionality. You have to be intentional about building these partnerships with youth and families. I'm challenged to leave today's conversation saying, how can I do a better job as a leader in this movement to make sure that families know how to access the data, have conversations around what it's telling us, and then the importance of using their voices to inform policy and practice, because we've seen that when people are educated, equipped, and empowered, change happens. And so I'm grateful for this dialogue and for all that we've learned today together.
Well, thank you all for joining us. It's been a really interesting panel today, and I'm so grateful for all of you for joining us. So we look forward to seeing you. Next month is on finance and financing mobile.
We're wishing you luck, Chelsea.
All right. Take care, everyone. Have a great day.
Bye-bye.
Thank you for joining this month's Mobile Response and Stabilization Services Learning Community session. Please take a few moments to complete the evaluation for this session using the following link being posted in the chat. We will be providing a certificate of attendance after completion of each session being offered throughout the entire series. So make sure that you are registered with the same name logged into each session so that we can confirm your attendance and the total time you were a part of this session. Please allow up to 10 business days for your certificate of attendance to become available in Ideas at the Institute. Any presentations, resources, and recordings will be made available to you within Ideas at the Institute. Once you are registered for the learning community, you will have access to all of the upcoming and previously recorded sessions. We hope you join us again for next month's session. You can access the Zoom link for each session and download a calendar appointment for that session by logging into Ideas at the Institute. Access the MRSS Learning Community curriculum and click the View button for that upcoming session. Thank you for joining us, and we look forward to seeing you at the next Learning Community session.